So I'd like to introduce Dr. Melissa Valerio. She is the Regional Dean at the University of Texas School of Public Health at Houston, Antonio Regional Campus. Dr. Valerio's intervention research focuses on identification of effective and culturally sensitive strategies for promotion of chronic disease management and prevention in underserved populations. Her research focuses, and what I know her for, is on design and translation of educational interventions for practice in the community. Dr. Valerio was awarded the Mentor of the Year award in 2011 by the Latin American and Native American Medical Association at the University of Michigan Medical School. She received the Circle Award from La Celebración Latina in 2010, and she's published in the area of asthma management, HIV prevention, health sharing decision-making, and health literacy. So today, she's going to speak with us regarding the role of health literacy and cultural humility in disease management. Dr. Valerio.
While I'm setting up, I'll go ahead and thank Senator Nathan Pulliam for your talk. Thank you for leading our efforts and our role in health disparities and addressing health disparities and cultural competency. I also want to thank Drs. Belcher, McFadden, and Stone for the invitation to join you today. What I'll do specifically is talk a little bit about the UT Health System in Houston. So the UT School of Public Health, there are 6 campuses. Houston is our primary campus, and I'm the regional dean at our San Antonio Regional Campus, where we serve a primarily rural population surrounding San Antonio, Texas. San Antonio is the 9th largest city in the U.S. Oh, not going to work. Oh, this isn't the slides, this is the JPEG. There we go. Oops. Here we go. Okay, that'll be better. So quickly, objectives for the session: define health literacy and its impact on health outcomes. I know many of you have been introduced to the terminology related to health literacy, the definition of health literacy, so I'll go through that and hopefully you'll learn a little bit different aspect of health literacy. Identify the association between cultural competency and health literacy, and also cultural humility specifically. Explain how historical experiences in healthcare influence navigation of the healthcare system, which informs a lot of my work in chronic disease management. So what I want to do is talk to you a little bit about patient and provider communication, because it's so important, and in that framework of not only health literacy but cultural humility as well, and how the patient works in navigating the healthcare system. So this is deliver our diagnosis in fruit, and hopefully this will work.
You gotta look at the doctor and look at his face to try to figure out how bad it is. You like, and the doctor gets sick of looking at your stupid face. You know, you have a grapefruit. Oh, you gotta get that out of there. Grapefruit, that's gotta go. We gotta get that.
Okay, so these are many of the experiences that patients face, and as the senator mentioned, how we communicate is important. And I like to start off with a little, taking it in and putting it in perspective from the patient's view. So literacy is defined as the use of printed and written information to function in society, to achieve one's goals, and to develop one's knowledge and potential. Really, the K through 12 system is what supports us in achieving this goal of literacy. However, health literacy, the American Medical Association, the Health and Human Services, as well as Healthy People 2020, released a specific definition of health literacy, and this is a definition that is used most often, which is the degree to which individuals have the capacity to obtain, process, and understand basic health information and services needed to make appropriate health decisions. So that's multiple levels of work and skill on the patient. And a lot of the definition places that burden somewhat on that patient to obtain information. The patient cognitively processes that information and uses that information. Why is this important? It's important because when you look at health literacy and inadequate or low health literacy, as measured by the current measures that are often used, the gold standards, the short TOEFL, which is the short test of functional health literacy, the newest vital sign, or the REALM, you're looking at inadequate health literacy as a stronger predictor of a person's health than age, income, employment status, education level, and race. So when controlling for all of those factors, health literacy, above and beyond those factors, influences health and outcomes. Over 90 million people in the United States have difficulty understanding and using health information. That's about 1 in 3 patients, 1 in 3 individuals, 1 in 3 in this room. Given our education, given our training, we will still have inadequate health literacy in specific contexts, in specific settings, when we are introduced to a new area of health. So another reason why it matters is that the costs associated with inadequate health literacy are estimated to cost between 3% to 5% of total healthcare costs per year. So that translates to between 75 to 125 billion annually. So significant costs related to inadequate health literacy, primarily around the issues of adverse events. So much as the senator described, individuals taking multiple medications, the dosage is incorrect, and not knowing, understanding when to take their medications. So as I mentioned, health literacy does vary by context and setting, and it's not necessarily related to years of education or general reading ability. So as we work with patients, as we work with the community, we need to understand that regardless of education, an individual in a specific context, in a specific setting, will have inadequate health literacy, will not know how to obtain information, will have difficulty processing that information and using that information for decision making, again, regardless of age, race, and background. So even the well-educated people with strong reading and writing skills may have trouble comprehending a medical form or doctor's instructions regarding a drug or procedure. I don't know if any of you have watched the American Medical Association training videos on health literacy, but you do see where one adult woman has had a hysterectomy, did not understand the informed consent process, did not understand what she was signing, has gone through that process, goes back into the healthcare system for follow-up care, and the word hysterectomy is used, a word that she recognizes. And until that moment, she did not understand that she had agreed to have a hysterectomy. So the impact, the words, the language, how we communicate, and what we use in our informed consent process without a verbal consent as well is very important for us to realize the potential impact. We also have individuals with limited health literacy report a lower use of preventive health services, primarily due to not understanding what their rights are for care to access, not understanding how to navigate the healthcare system, less knowledge about one's disease, worse self-management skills, increased risk of hospitalization due to waiting for acute care, higher medical costs due to the need for acute care and the low use of preventive health services, and poor health status overall. You also have higher all-cause mortality rates associated with inadequate health literacy. So it is strongly related to multiple outcomes over time. One of the reasons that this becomes more complex are that our medical care regimens are increasingly complex. They are more successful, they create longer life, but they're very complex in many ways. So a patient uses an array of medications, patient self-care, insurance and paperwork as well, but also needs to take care of their indoor environment, their outdoor environment, other issues, family care, coordinate care, and other. As an example, in asthma in the late 70s, early 80s, it was a theophylline pill was prescribed. Now we prescribe inhalers with spacers. Most patients don't know how to use the spacer, do not use the spacer after leaving the doctor's office. Controller medication and rescue medication, not understanding that the controller medication is for daily use to maintain and to even during seasonal asthma related episodes that you should maintain use of the controller medication, the use of rescue medications, how and when to use it, daily testing of peak flow rates, interpretation of those peak flow rates, what do they mean, even with the asthma action plan and use of the green, yellow, and red light zones. Dose of prednisone as needed. Many have the prescription that is filled or ready to be filled and make that decision on their own, identify and make changes to indoor and as well as outdoor environment. So that is guideline-based care, guideline-based quality care that a physician translates and delivers to a patient. Therefore, a patient will interpret that information, use that information to make decisions on a daily basis, and it can be very complex. One of the reasons that health literacy is a national healthcare priority is the Healthy People 2020 objectives focus on use of health communication strategies and health information technology to improve population health outcomes and healthcare quality and to achieve health equity. The overall objective, though, is very broad and insufficient in many ways. It says increasing health literacy skills. So what does that mean? And how do we do it? That's a challenge to us as healthcare providers and as community practitioners. How do we go about increasing patients' ability to process information, to use that information, to exchange and engage in that decision-making process? So there are multiple layers here. It is also one of the Institute of Medicine's top 20 priority areas for national action to transform healthcare, and there is a national action plan to improve health literacy. So we do have a US-based focus on health literacy and focusing on improvement of information use as well as language and communication. The objective 11.2 of increase the health literacy of the population, Rima Rudd, Dr. Rudd is at Harvard, and she worked quite a bit with a subgroup that identified and looked at what does this really mean. And in about, I think this report, a subcommittee report came out in 2008, and it identified 3 specific areas of interest related to health literacy in the population. And it broke down those activities that patients engage in into these 3 specific groups: clinical, prevention, and navigation of the healthcare system. Clinical activities were associated primarily with coming into the doctor, those clinical encounters, diagnosis, and treatment of illness and medication, whereas prevention was more of what you do prior to engaging within the clinical system and associated with maintaining and improving health, preventing disease, and intervening early in emerging health problems. The navigation of the healthcare system piece has also been a great focus of many, and this includes signage and other at hospitals. How many of you all have gotten lost at the hospital? right? Yeah, okay. It can be really tricky and difficult to navigate, to find where you need to go for that x-ray, where you need to go while you're in pain and moving through that system 3 floors down, because you never knew that the hospital had 3 floors that were below ground one, and now you're in there and you're trying to find that x-ray room, you're trying to find someone to help you with your CT scan, MRI, or other. And that was myself as well at the University of Michigan when I was a patient. So the Patient Protection and Affordable Care Act, as Senator mentioned, 4 provisions with direct references to health literacy. This includes the linguistic piece, cultural competency and linguistic competency. Looking at other multiple provisions with indirect references related to health literacy include insurance reform, outreach, and enrollment. Many of you are involved or volunteering in the process of enrolling patients in coverage with the ACA. Individual protections, equity, and special populations, specifically related to health disparities and thinking about health equity. Workforce development, as we train physicians, nurses, and other healthcare providers in thinking about the use of jargon, medical jargon, and other information, how is it delivered and how is it more appropriate? Including yesterday, the Institute of Medicine has a health literacy roundtable that released technology and medical information delivery communication. So movement to the EMR, patient portals, how are patients navigating those? Are they using them? Are we using them? Do we use them effectively? In many of the conversations that I've had with practicing physicians, even the setup of the room, the environment of the room, the use of the EMR is stationed in one place, may get you to place your back to the audience, to the patient, right? So that then again does not promote good communication. What was Wanda doing? A lot of nonverbal cues to the provider, right? I don't understand. Kind of staring, looking, squinting, shaking your head up and down, right? All of you all that are in clinics, work with community partners or community participants in research or other, have seen that look, have seen those questions, have seen the nodding heads and agreeing with you, even though you probably know that they're not agreeing. So health information and language, again, the use of medical jargon, but I'm also an advocate for using both, finding a way to use both, because many times patients do not come back to you. So empowerment of community, cardiovascular disease, heart disease, so mentioning both terms, hypertension, high blood pressure, in a way that makes it more available to patients, because again, the next person they see may not use one or the other. They may use a more technical jargon term. When that patient navigates that system, you want them to have be more empowered and recognize that term, recognize that word. Public health, health promotion and prevention and wellness, and innovations in quality and the delivery of and costs of care. So how is it associated, again, to costs and care? So Dr. Posh, Orlo, and Wolf have the conceptual framework and identify the causal pathways between health literacy and health outcomes. And I'm going to try to use the mouse. And yeah. So what we have is that terminology in that box of health literacy, inadequate or adequate health literacy, and predisposing factors that may be associated include race, ethnicity, education, and age. Given inequalities, given the K through 12 system and other, so we know already that some of these variables may be impacting health literacy. You also think about occupation, so insurance and the level of insurance. Is it an underinsured population? Employment, those that work in contract or piecework. I work with a lot of vulnerable populations on the border in manufacturing companies that will not take time off specifically because they're paid by the piece and do not understand policy and time. Income, social support, culture, language, all impact health literacy, as well as some of the cognitive, perhaps cognitive, vision, hearing, verbal ability, memory, and reasoning as we age. So these may be natural progression as we age. But in his framework, and one of the reasons why I prefer using his framework is specifically because there's an understanding that it is not only at the patient level, the factors that are impacting inadequate health literacy, but at the system level, at the provider level, and other extrinsic factors that may impact. The role of mass media. Many of us know that individuals are obtaining information through the internet. We all do it. We all search for what's happening to me, but many of us in this room may be going to .edu, .org, .gov specific organizations. I tend to go to the Mayo Clinic, and look things up. But other individuals may just be Googling a straight Google search. I'm feeling lucky, and what comes up. And it all depends on what that is. The other thing that we have found in our research is specifically that whatever that is, and it may be through a credible source, the comments section are very important, okay? So specifically because a community member will engage and feel that this individual went through it. This is the expert's information that's presented here. But here in the comments section are individuals that have actually gone through this, have gone through this test, are in the testimonial piece, and how that brings in an individual, and the credibility of some of those comments is greater than some of the information, the scientific-based information that we provide. So we also have to be aware of how media, social media, and other impact self-care. At the provider-patient interaction level, this is where a lot of my work is focused on not only the knowledge, beliefs, and participation in decision-making, so that cultural competency, understanding the culture of a patient, of an individual, and how that plays into that interaction with that provider. Are they following up with care? It may not be that they don't understand when their next appointment is, but it may be that the accent. We have many patients who mention accents in Southwest Detroit, in Eastside Detroit, Alabama, and in Texas that we work with through FQHCs, so federally qualified health centers. The provider level factors, communication skills, again, teaching ability. How are you teaching? How are you communicating as a provider? Again, going back to that AMA video, one of the teach back method, in Ask Me 3, train your patients to ask questions in a specific way, to feel safe in that safe environment of asking those questions. Time. We know that at the system level, time is precious, as well as reimbursement and other factors that come into play. Patient-centered care is a focus, and will continue to be, hopefully, in the future. So how all of these factors come in and impact health outcomes over time. The why now, and why do we continue to engage? Well, one is we understand that health literacy is impacting health. So where can we intervene? What can we do? One is culture and society. How do we teach? How do we understand culture and society? How do we engage as a system in our own culture of health? Because physicians have a culture, nurses have a culture, we all have. Public health has a culture as well. And it may be a good reputation, it may be a bad reputation at times, but it all depends. The health system itself, signage, you would be amazed at how much buildings spend on signage, and signage that ambulatory, what does it mean to someone? So words, language. The education system, the K through 12 system, would be a place where we can begin to revisit health education, revisit how we're introducing health in the classroom. One of the issues is related to, again, the senator mentioned translation services. Many families depend on children to translate and prefer the child to be in the room, even if a translation service is available. what we have found is young women, teenagers, who are navigating the healthcare system for their parents. They speak English, their parents don't speak English, primarily Latino, Mexican immigrants in Southwest Detroit is the population in the family I'm thinking of as an example. And what happened was, young girl, 14, and she was very proud that she hadn't sent her dad to the hospital, had taken over his medication regimen in 5th grade, and she was now in high school, skipping school to go with dad to his appointments, but that pride and that culture. But within that household, we know there was a shift in power, a shift in dynamics. Dad's quality of life. He was trying to manage and navigate health care for diabetes. What happens to many men with diabetes? You're talking about impotence, you're talking about sexual dysfunction. He's not going to bring those quality of life topics up with his teenage daughter in the room as translator. So again, as a system, what are we doing? What are we promoting while being respectful of that culture as well and that pride within that household? And again, those how health literacy directly impacts health outcomes and costs. We also are working within new care delivery models where we are engaging patients in care, identifying priorities of communities for care, and functioning in that way. So looking at the community level, what resources are available and policies, self-management support, and so we engage many times with others in providing care. We understand that the health system, patients leave. Patients are engaged for 15 minutes to an hour on a daily visit, or engaged in a hospitalized or other. That organization of healthcare, the delivery system design, decision support, clinical information systems are all engaged and important as well. We want to, teach skills and have an activated patient, an informed and activated patient that can engage in the system. And then also a prepared proactive practice team. It's bi-directional. And much of the work that we're focused on developing is promoting that bi-directional exchange and facilitation to improve outcomes over time. Again, that patient-centered home includes comprehensive care, coordinated care, accessible services, quality and safety, and is patient-centered. But in many times, culturally, some patients don't want to be involved in their care. They want the doctor, they see the doctor as the expert, they want the doctor, the nurse, to provide them with what should they do, answer that question. So navigating that and facilitating some type of decision on how engaged or how activated a patient is going to be can be very tricky. So in the senator's work, her description of cultural competence is very different than some of the times and in the past what systems did in response to the call for cultural competency and to address cultural competency resulted in very cookbook type of trainings. And it didn't really reflect the culture, but was more introducing stereotypes. So the traditional notion of competence in clinical training as a detached mastery of theoretically predetermined body of knowledge. So a lot of the research was then used to facilitate and engage in identifying patient-specific needs. While some of it may be true, as a fourth generation Latina, when I am sitting in the room and someone comes in and automatically starts speaking to me in Spanish, I may be offended, okay? So how are you going to engage with patients and what are you going to do? What is the assumption? So in looking at old training styles, this was very much of a cookbook type of approach. And so what I've focused on specifically is cultural humility, and that incorporates a lifelong commitment to self-evaluation and self-critique, to redressing the power imbalances in the patient-physician dynamic, and to developing mutually beneficial and non-paternalistic clinical and advocacy partnerships with communities on behalf of individuals and defined populations. And this is more in line with the Senator's definition. So this is that reflection as, what do I bring into the room? What am I providing? And how do I come in? How am I engaging with patients? How am I engaging with participants in my research? Because I'm not a physician, but I do engage patients in clinical settings through my research. So that specifically is a reframing of looking at cultural humility and understanding that as you check yourself, you may be able to communicate with those of other languages, other cultures, because you're being respectful in that sense. And that gets back again to the paradigm that the Senator presented us. So effective communication between patients and healthcare providers is a critical element to quality healthcare. Becoming aware of patients' attitudes, beliefs, biases, and behaviors that may influence patient care can help clinicians improve access to and quality of care. So this is one of the articles that I've reviewed, and this is specifically to promote effective communication and delivery of culturally competent health care. And again, it's becoming aware of that surrounding of yourself as well. So the evidence-based practices in that intersection. So many of us in training, we're focusing on evidence-based care, best practices, guideline-based care, but then we have our clinical expertise and training as well. And this intersection that comes into play includes that patient's values and preferences. So in engaging with patients, we need to understand all of those, that regimen, right? The gold standard of care for an asthma guideline-based care delivery. But then also looking at mom. Mom is very similar to the Senator's description. Mom is incarcerated. Grandma is the caregiver. Grandma is 80. Grandma is navigating her own health as well as the child's health. These are real life stories. And taking that into account, but not dismissing the quality of care, but working with that patient to navigate and to balance that care, but still having that guideline-based care integrated into that specific setting. And it is difficult, it's challenging, but to address health disparities, to improve outcomes, we need to step back and take the time to do that and to really assess that setting. So that informational balance includes that patient, and this is through a cultural lens in looking at the providers, the patient, and the family in many ways. So thinking about that broader picture and how it's all working together in care delivery. So our projects to address health literacy pretty much span the life course. And we have projects that address adolescent health literacy. I use community-based participatory research approach. So I work with community partners to identify the priorities as well as the way that we move forward with grant applications, programs, and service delivery. And with adolescents, we specifically look at diabetes prevention, and that was one of the stories that I shared. We were specifically looking at prevention of diabetes in high-risk populations, African American and Latinos, as in looking at first-generation children with an adult parent or caregiver that had type 2 diabetes, so at high risk. E-health literacy of older adults, Winter Texans in South Texas, from up here, East Coast as well as Midwest, navigate down to South Texas, and are heavy users, much like Canada, going into Mexico, into the border states for healthcare access to medications and other services. So we've worked with them in how they navigate that system. Health insurance literacy and awareness of the Affordable Care Act. I'm working with the state of Michigan to develop training of physicians, nurses, and other providers in the Affordable Care Act, as well as insurance literacy. Health literacy of manufacturing workers, and this is some of the work that I'll highlight as we have time. The specific area that we address, and Kathleen Harrington is at the University of Alabama, Birmingham. She and I have been funded to look at this gap. When we looked at health literacy, we found that the majority of recommendations focused on print materials. So how you develop print materials, how you engage patients with specific print. It could be online or handouts or other. I feel that that is necessary but not sufficient in many ways. So focusing on print materials that are at the 6th grade level that patients will take home, refer back to, and use and navigate. But how do patients and providers communicate within that setting? It's verbal. It's an exchange of some quality. Maybe not great quality, but it's an exchange, or should be, and it is primarily verbal. So 90% of the visits require some type of verbal exchange. What brings you here today? What's happening? How are you feeling? Different questions, right? So it's prodding, it's some type of exchange. So we have focused our work on verbal exchange health literacy, which is defined as the ability to speak and listen that facilitates the exchanging, understanding, and interpreting of health information for health decision-making, disease management, and navigation of the healthcare system. So in this work, what we've primarily done is within the frame of health literacy, we're focusing in on one area. Numeracy is another, and I'll share this with you. So here is verbal exchange health literacy, which is defined as listening and speaking, but you still have this broader aspect of health literacy, which includes the reading and writing and the numeracy, so math skills specifically associated with medications and use of information, carb counting. Highly recommended, but how many people understand it and will do it? And in our work, we've also identified, and I'm going to focus in on this relationship characteristics, the history and type of interactions, satisfaction with relationship and role expectations, and how it influences a patient's use of health system information. So these are some quotes from different groups and these are actually individual one-on-one and conversations and key informant interviews that we conducted in Detroit site when I was with the University of Michigan and University of Alabama, Birmingham. I asked questions and then I write down whatever they say. So much of that is asking some specific questions, but then writing down to remember later, to use that information for later. So here's where some of that print material comes into play, that you are going to refer back to it. But that exchange is important because the print material is not enough. They also want to hear what that means for me specifically. I ask them to please explain to me like I was a little kid. So void of jargon, medical jargon, using specific living room language. What good is the pamphlet on the information if you can't read well? Okay. So who do they share that information with at home? Who's going to make time to help them navigate and understand that information? And then the importance of that medical home or that physician relationship. He knows my history, and so I'm comfortable telling him everything. So when someone doesn't know their history, what happens? When they don't have that same setting, and I don't necessarily see the same physician. When I was growing up, rural South Texas, I saw the same doctor, Dr. Nissenblatt, from age 0 to 18, and I cried when he said I couldn't come back. But that home doesn't exist anymore. Even in rural Texas, you have a practice and you have multiple physicians, multiple providers within that practice, but that practice becomes your medical home. And sometimes that isn't in place for many. I keep telling them, don't give us the technical. Okay. So don't speak to me in technical jargon terminology. Maybe if we had insurance and we had a regular doctor, if you have an emergency, he's more apt to say, come in. He's going to work you in to see what's going on as opposed to an appointment for next week. I'm not going to sit all day in the waiting room because I'm going to go home. I go to the emergency room. So you see how some of that understanding, the navigation of the healthcare system impacts outcomes over time and is related to behavior. One of the issues that we found is that there was a lot of, whether it's a misunderstanding or a mismatch. So we may have a broken system. So many of us in this room have insurance, we're covered, and we call in and we may not get an appointment for a week or a month. But we're cognitively aware of that's how the system works, or we work within that system. We accept it unless it's an emergency. So how we navigate and understand that perception with certain individuals was that I'm being discriminated against, I'm being treated differently, I'm being treated less than. So we need to be aware as practitioners that that is the information that is how that information is being perceived. And it may be true, I'm not dismissing that. However, we need to also look at our own lens and what is it a broken system, or is it specifically that we are treating individuals differently? And I think that comes back to teaching the navigation of the healthcare system, the expectations as well. And I don't get seen, I have to wait in the waiting room for 40 minutes. I know many of us in this room have waited for 40 minutes. It's understanding the system. And again, whether it's broken, yeah, I believe it's broken and we shouldn't wait for 40 minutes, but it happens. But we need to educate and we need to understand how we navigate that system. I would do a lot of internet searching afterwards. So looking for information, looking for an answer. Always I try to find information on the internet. I get that there are some things that you must do, some things that you should do, and some things that you could do. It would be good to differentiate between those. The must, you need to have a clear direction. So tell me what I need to do. The ask me 3. What's wrong with me? Why is this important? And what do I need to do when I get home? Okay? So kind of gets to this statement pretty close. I don't know what I'm taking it for, and they aren't explaining nothing to me, and I don't take them. Okay? You, the doctor, you know you should be telling me. You pick and choose what you want to do. So as a patient, you pick and choose what you want to do. Many of us do, and use that information in different ways. So quickly, I wanted to take you through one of our projects, the Trabajando Juntos Working Together project, and this is addressing obesity in the Rio Grande Valley. So this is a manufacturing population, primarily males, who work in maquiladoras, which are in Texas, not in Mexico, but they usually have a sister company site in Mexico, which they described as being very different, including healthcare services on site and cafeterias on site, which in the US side, it did not have those variables. So it was very interesting to learn about this field. Health disparities, as we know, disproportionately impact Hispanic groups in the US, those of Mexican descent, Mexican origin, and immigrant populations from Latin America, and have disproportionately burden of those health disparities. Obesity and limited health literacy are both major health problems. We all know that. There is a focus in that, public health as well as medical focus. More than 1/3 of U.S. adults are obese, and we know that a large proportion of the U.S. adult population has limited health literacy. So we found that there were very little interventions to address health literacy and obesity in Latino adults, and that was our primary focus. And we moved forward to design a tailored behavioral intervention focused on promoting health literacy as a strategy for obesity control and prevention, and then work to address individual and structural level factors influencing obesity in the population. And to do that, we took into account, and this specific framework was adapted following focus groups and one-on-one interviews with the population, with the manufacturing employers as well, and looking at the worksite factors, insurance status, paid time off and break policies, shift work, and worksite facilities. We were also very interested, and the manufacturing companies were very interested in working with us, specifically because they felt that our program would allow them to meet ACA-specific needs. And so they were also interested in addressing presenteeism and absenteeism in their employees and facilitating and preventing diabetes as one of those factors. So individual background factors in the specific population was a high family history of both obesity and diabetes, personal experiences with chronic illness, diagnosis, demographic factors and general health status, functional health literacy, and health-seeking behaviors. And we specifically wanted to address outcomes, preventive, clinical outcomes, and functional health literacy. So functional health literacy in really looking at and using information to move forward with health. Our partners included the South Texas Manufacturers Association, Texas Manufacturing Assistance Center, and interdisciplinary groups. This was a partnership of over 60 employers and companies were represented. They still come together for quarterly for just to discuss health issues. We buy them lunch. We want to keep them engaged. We're hoping that this gets funded and we can, again, disseminate the project. So our first step was to conduct one-on-one interviews, and we specifically found that those with inadequate health literacy had significantly higher rates of obesity, and there was limited healthcare coverage, and it really did impact healthcare access, utilization, and uptake of prevention and screening services in the population. Remember, this is a male population, primarily male, so even though Medicaid, Medicare may be available in the community, this male population was not engaging in those preventive services at all. And we had identifying specifically what was needed, where we used key informant interviews with the managers, and then also focus groups and key informant interviews with the patients, with the manufacturing workers. So in our three-phase study, what we came up with was the development of tailored health literacy intervention to address navigation of the healthcare system. So when they did go into for healthcare access, many felt that they did not receive information. So they'd have to come a second time to get blood work results or to get any results, any type of information. So they felt that there was a limited engagement and response to their needs. So what we did was we specifically addressed the obesity issue, type 2 diabetes prevention, and navigation. This is some of the materials that we designed were in messages using symbols, cultural symbols that would be recognized. So this is a loteria style imagery. Loteria is kind of like a Mexican bingo game that is used, and the cards have images as well as numbers. And this is 30 minutes physical activity and hydrate, okay? So all of the images and the cards, everything that we use, text messaging and other, had a lot of cultural variables and looking at specific language promotion, as well as promotion of local foods and physical activities that were readily available in the communities, and working within the work site, which was very important to them. This is a breakdown of the intervention and specifically what we addressed, and given their need within the work site only at lunch, and they were not going to engage prior to work or after work, so we also had to incorporate that. And another area, 5 minutes, okay. I wanted to, just quickly, I have 2 slides related to colorectal screening in South Texas. And we're looking at a high-risk population, rural area, and common barriers that include cost, lack of transportation, and accessibility to facilities. And I just wanted to share some of the comments from the population, because we're facing some unique challenges that are cultural to rural areas as well as the population. Here in the community and the hospital being so small, everybody knows everybody, and it's like, oh no, I don't want them checking my behind. So challenges, unique challenges of how do we engage in care delivery in a population where, yes, everybody knows everybody, or may be related. So we're trying to come up with our intervention strategy related to and specifically tailored to this population. Well, for me, it's self-conscious because of being examined in that particular area, and what all has to take place during that examination is kind of embarrassing. So some of these are in the literature, common barriers, challenges for different variables in screening, but they're challenges for us as healthcare providers to think about, to address, and to come up with some solutions in communication, and also promoting that bidirectional communication, because I think in many ways, if we have that exchange, we can address some of those specific barriers and challenges that individual patients are facing, and given the specific settings. So thank you for your time.
Hi, I was wondering 2 questions. So I know that in CMS there's been some push towards and some funding towards professionalizing some sort of lower level professionals in the healthcare system around care management. So somebody actually correct, yeah. And to that point, I think what we see a lot is the provider to provider communication as a big barrier as well. So specialists reluctant to communicate directly with a primary care professional, and so patients receiving inconsistent instructions from a number of providers.
Mm-hmm. Yeah, so we work closely with community health workers, and we have to have them all trained, very specifically certified, and then also individual project training. We also let them know that they're not health professionals, right, and they cannot diagnose and treat. So a lot of information. Also, we have a pharmacist. We have case study review on a weekly basis for one of our projects. So those cases, there is communication, there is dialogue with the healthcare provider, so with a physician nurse team, as well as mental health specialists. So that's how we've handled it, but it's costly, it's time consuming, and many of the community health workers are out in the field, they're meeting patients, they're navigating, and because they represent the community, they may not have that skill as well. So, new topics, and I think very important question. Thank you.
Other questions? Well, let's thank Dr. Valerio again. Thank you very much.